Sawadee-krap. Hello, all distinguished guests. Welcome back to the second webinar meeting hosted by the MU-JHU NCD Research Collaborative Center. My name is Dr. Titipong Tankampuan, the director of the MU-JHU NCD Research Collaborative Center. As we know, COVID-19 creates a massive impact for the global population, such as physical, psychological, societal, as well as the economic burden. The pandemic has been affected the entire system and present an unprecedented challenge to population health and well-being. Today, we will focus on the psychological alteration among healthcare providers, emphasizing nursing profession during COVID-19. The agenda for today, we will start with the psychological impact among nursing students presented by Assistant Professor Tamar Rodney. Then, Professor Ritin Fernandez will address the psychological impact among nurses at the frontline service level. Then, Associate Professor Yachai Sitimongkon will present the study of psychological impact among university students in Asia, including Thailand, Taiwan, and Indonesia. After that, we will open for the Q&A session. May I remind you that if you have any question during the presentation, please type in your question in the chat box. We'll start our question after all three speakers finish their presentation. If you have any question, please type in the chat box during presentation. I remind you again. First, I would like to introduce the first speaker. She is an assistant professor at Johns Hopkins University School of Nursing. Her career goal is to change the way healthcare professionals approach diagnosis and treatment planning for individuals with mental health needs. Today, she will present on the topic of addressing the mental health impact of COVID-19 on nursing students. Please welcome Assistant Professor Dr. Tamar Rodney. Hello, Tamar.
Hello, and thank you for this opportunity. It's my pleasure to be with you this morning. And I am going to be speaking with you about how do we address the mental health impact of COVID-19 on students. One of the enduring photographs or memories that I think we will have from the last 18 months is what is symbolic of COVID-19. And I share this with you because for the last 18 months, it has been mostly informational. When we see this picture, we know they're mostly information that we need that might be attached. What I would want us to be mindful of is what this will mean for many of our students in 5 years, in 10 years. Most likely will not just be information, but possibly traumatic, remembering what this time meant for them. And so my objective this morning is to, bearing that in mind, is to look at how pre-licensed nursing students had concerns related to COVID-19. What are the impacts specifically on their education and clinical practice, and identifying areas that we can change specifically within the educational format for our students. And I chose to focus on our pre-licensure students because I thought they were a more vulnerable population, not knowing many of what the nursing world demands, and maybe some fear of even joining the profession of nursing, being in this difficult time and the strain that nurses have been facing. So why do this kind of research? Apart from thinking that it's important, we do know that one of the major things that change with COVID-19 is how we deliver educational and informational content, meaning the platform on which we deliver. So here we are this morning, international platform, but on Zoom. Yes, it happened before, but I think even in the educational sphere, this has been more utilized to the point where it also almost became a norm. But what I would want us to think about is what is the impact on this rapid change for those students? We also know that for education to go right, there is an interaction between brain health and mental health. And this is not often focused on for students because we're more focused on getting the information in and getting good grades out and completing competencies. But in the background, I would like us to focus a little bit on what does it mean for our students' mental health. What are some of the allowances that we made for our students? Is it turning in assignments late, considering how COVID might be impacting them, as well as their families and the environment that they're in? And also what changes they had to make in order to stay in school, to stay engaged and still be successful. And lastly, I want to look at what is the historical perspective. So while we have not seen anything like COVID-19 before, we have come close. And so I'll start with that aspect. So what does history tell us? So we know that online education specifically saw some reviews on faculty struggle to deliver this information. And those struggles are surrounded around how do you deliver authentic nursing experiences, often considered the real experience as opposed to virtual? How do you appropriately assess students' preparation? Meaning, if a student is engaged in only virtual preparation, is this enough? And how can we develop scenarios that will sufficiently prepare our students? So that was from 2009. We also saw some reports from H1N1 on their pandemic effects. And what we know is that the changes to how a pandemic impacts us changes variable from the pre, early, and mid-stage outbreak. I'm not sure where we will rank COVID-19 at this point, because maybe a few months ago I thought we were on the mending end, but with variable variants, we're not so sure anymore. So we're still in an era of unknown. How do we then prepare for a second wave? That was some of the interactions with H1N1 that were considered back in 2010. How do we prepare for future disease outbreaks? And we don't want to say I told you so, but maybe if we're taking some of this on board, we would have a better approach to what we're dealing with now. And importantly, how do you promote positive public health behaviors among young people and students? And this is where our nursing students will play a great role. And again, these were concerns with no answers generated from those research. But we also have data early on specific to COVID-19 as to what is happening. So one study out of Israel looked at the prevalence of anxiety among students, and they saw that there was severe anxiety at 42.8% among students. I just put as a side note here that one of the things that they found that was helpful was humor. And I completely agree with this, because some of this is so devastating. If you don't find some of it funny, there's no other way that you can cope. But I digress. One of the other things that is impacting students coming out of Spain is the financial, family, and emotional problems that are associated with higher levels of stress. So again, we're looking at our student population, but just be mindful that they sit in a larger sphere of where they have other demands, some of which are financial, to pay for school and to pay for other resources, but the impact on their family and how that might impact how they succeed in their education. And the last one I'll share is that coming out of China is that individuals that were closer to what they call the COVID-19 zone, areas of higher concentration, had stronger anxiety and anger. And I'm not so sure this holds true anymore, because I struggle to find a higher zone of COVID-19 because it's impacting everywhere, literally every country at the same time. So looking ahead, I thought, yes, we need to have an ongoing research, but how exactly do you do this? And trying to be authentic to the process, one of the things that I thought was really important is to ensure that while I design this research is to have student involvement, so current student involvement. And I'm fortunate to be in an area that we have students who are always interested in offering their time for research. And so I didn't just want them to come in and write a paragraph. I literally wanted them from day one. How do we design the research to ask the right question? How do we interpret the results that we get? And what do they think are future research ideas that we should look at? So I see this project as ongoing, and very, very grateful to have had a group of 5 students who consistently stayed with me throughout the project and assisted me with every step of the way. And I think this is one of the things that makes the data a little bit more meaningful. And for me, easier to approach, because I could get rid of some of the biases sitting in a lecturer professor position. So they wanted to know, so I'm calling my students, they're informed opinion. They wanted to know what was different. And the things that they highlighted were that we need to talk about the rapid change, and that rapid change was going mostly from in-person to online format. The home environment, what was that home environment like for students who had to now attend classes from home? And so the home environment became school, it became workplace, it became daycare, also became an escape. But can all those things fit feasibly in sometimes the same room? And then there are practical components for students who had to move away from maybe living quarters that they're renting, to move away from a different location that they may have moved for school. What are the impact on those students? Do they then decide to go home? Do they give up their rental space? And I'm happy that these components came out because they're not often things that we think about. We want our students engaged in the classroom and very rarely we ever think about, are they 100 miles from home? Are they renting? Are they living? Are they in a home that they own? And so I was very grateful when they raised these pieces because I don't think I would have thought of them outside of them saying so specifically. So let's talk about the piece about change, for instance. And I share with you two photographs. The one on the left is back in the old days where we could do in-person simulation using our robots, being very close to each other, talking without masks, mind you, to sharpen our practice skills before we go out to touch real patients. And on the right, we've upgraded, included, but have the advantage of using simulation with masks, socially distanced, and hoping for the same outcomes. But while we have the opportunity to do that, one of the things I want to know is, does it still achieve the same outcomes? The short answer is yes, without a statistical plan here, because the students did appreciate the opportunity to still progress, and that was really important for them. Another thing the students wanted to know was, how do they support employees? And this I thought was extremely interesting. I'm like, you're worrying about the employees? And one of the students said, yes, because if my preceptor is not okay, I won't have a good clinical experience. I'm like, okay, it's very thoughtful, but I think that's also a sentiment that's shared mostly by nurses, that we think about the others that not only that we serve, but that helps us. How does it change the outlook for the field of nursing? Will nursing students not want to go into nursing? Will they choose a different career? Will they feel invigorated for having an opportunity to respond to the needs of COVID-19 and more patient burden? Or will they be deterred, like, nursing is not for me, I'm not cut out for this because I'm at higher risk? Two other things that we discussed was students wanting to volunteer and volunteer frequently and for anything. So simple things like making masks, volunteering to do counseling for individuals who wanted to know about the vaccine, which I thought was very admirable, stepping up to a role that they weren't fully prepared for, but were willing to volunteer whatever they could. And then the last point was, will they still have access to school resources? And by this, I mean not computers, but the things that help students outside of the classroom. So groups, will we still have our groups? Will we still have our little clubs and committees for individual support within their cohort? So that told me that the physical environment is important, but also the things that we do outside of the classroom are the major changes, major areas that the students wanted to look at. So I want to just put a scientific lens on this before we go any further, that one of the things that inform most of the research I look at is, in assessing any area of change, is what do our models tell us? And this can be applied to almost any human behavior, that once there's a stimuli of any sort, and this is from Roy's adaptation model, individuals, human beings, have a process of coping, several different lenses. But what we usually see as an outcome is a behavior. And that behavior can be significant to how bad that stimuli was, but more importantly, how appropriate that coping process was. So I use Roy's adaptation model to inform that if COVID was a stimuli, good or bad, the coping processes was the determinant of how that behavior change would come. And I'll just share a brief example that during the first couple months and we're teaching, you would frequently get emails with varying emotions. So one of them might be sheer panic, I don't know what to do, can you help? To maybe a little bit snippy, very demanding. And you really had to take a step back as what is triggering some of these behavior changes, and how are some of the things that we can do in that moment to change or get a more appropriate outcome from our student, not putting it on a personality, but as a process of change. So the big ones that I thought to include in the survey was students concerned about not graduating in time, not knowing if they'll be good enough to be a nurse. Would it be helpful for them to continue as a nurse at this time? They were also concerned about nurse/preceptor burnout and losing that one-on-one interactions with their patient, so they could do things and feel things and see things and an opportunity to correct mistakes. So I included these questions in an online survey via Qualtrics. It was distributed worldwide from our IRB because I thought this is impacting everywhere, everyone, anywhere at the same time. So capturing a good audience of nurses in a pre-licensure context would be important. And the primary things that I wanted to look at is change, but keeping in mind that it's the concerns from a student perspective, not mine, but also including something scientific, as in using the Beck's anxiety inventory to assess what were the anxiety levels of these students as they look at the changes within their education and clinical context. And so this was our student profile. So within, I won't calculate, June to September, we got 228 responses or complete responses, fairly young cohort. So 68% of our students were below age 26, most identified as cisgender women, most were never married, 78% married, so single, and 67% were from the US. However, there were 8 countries represented, inclusive of Thailand, which I was very thankful for, and I suspect a few from Mahidol University. So some of the important highlights that I will share with you now is what our students' concerns were. Delivery of educational content. Pre-COVID, they preferred an in-person format. Online, 19% preferred pre-COVID, 19% preferred online and 35% a hybrid. What we saw is a greater appreciation for in-person, and I think this is one where you get to choose the devil you do and the devil you do not, and once you don't have something, you want it a little bit more. So in-person preference rose to 65%, and a drop to online, which at 12%, and only 22% preferring a hybrid format. And considering this, what did that tell us about our students who were, most of them were switched sometimes completely online, some had an opportunity for hybrid, but for a long while, none of them had an in-person contact. And what did that do to their motivation towards education, considering that this is not what they would want in an ideal world? 64% of our graduates of our students rather were undergraduate, meaning that they're getting their first bachelor's degree. So again, I want to share that this is the first time that they're getting a higher education, and their want is I want to be in an area where I can touch, feel, and see things, but I'm not getting that. So I just want to be mindful of how want versus what is available impacted our students. For the BAI, this is a 21 item rank from 0 to 3 as to what our students wanted. And I specifically chose this not to get any diagnostic criteria, but to see where students fall between mild, moderate, and severe, which is the ranking for BAI. And this is important because in previous research I've done, it's always important to follow the individuals who don't necessarily meet that cutoff area, but the symptoms affect them equally severe. So what we saw was 23%, which is very alarming, are reporting moderate to severe anxiety levels. But for the other 77% is probably where I would focus most of my energies, because while we can easily identify the 23% and supply resources there, it's also very easy for that 77% to convert within a couple months to get into feeling symptoms of moderate and severe. So I share this as a researcher and to say, when we see numbers on the higher end, this is primarily our focus to say, yes, this is very bad and which is where we should focus. But it also paints a story as to what are other individuals feeling. Yes, it allows us to allocate resources in an amenable manner, but it also says, here is an area that you also should pay attention to. One question that came up with our student group, which I thought was extremely interesting, was I'm sharing with them, there's this tool and it's well validated, has good integrated reliability. And they're like, yes, but why don't you just ask me? And that was the statement that stuck with me, to say, just ask me how I'm feeling. Ask me how stressed out I am. And the best way for me to represent that was on a sliding bar. We went through multiple different, so like, how do I ask you this one question? And the question was, can you please just rate how stressed you feel right now? What I found was that over 67% of our students said their stress level was over 50%. So 23% for the BAI looks bad. This, I think, is where the alarm bells went off. Only 8, like singular 8 individuals rated their stress level as 0 to 9. Which another way to interpret this is 92% of our students are experiencing some sort of stress. So again, this was a powerful realization for me, because I thought we get lost sometimes in the numbers and the validation of tools. And sometimes what our students want, our specific population, is a simple question. And this often can be found in one question to answer, like, tell me how you feel right now, and I will tell you a more truthful answer. So I would go out on a limb to say, maybe this is a truthful answer for how stressed out our student feel, but equally alarming to say, we needed to do something. But I wanted specifics on what areas am I going to focus on. So there are 5 questions that I ask our students about specifically, outside of the numbers, just tell me. Another important thing that I will share is this. You usually add a few questions. Is there anything else that you would like to tell me? Is there something that we haven't asked that you should share? Every single box for this 200+ survey was filled out. And that was completely touching, but also heartbreaking that they took the time to share, outside of clicking a box and a number. Let me tell you how this impacted me. And so at the moment, I'm working with a few students to analyze this in a very thoughtful, qualitative manner, but I will share with you some of the feedback from our students. And I produce this word closer to show the highlighted words, as these are the areas that students said affected them. So school comes in the center, which is not necessarily a surprise, but there's also clinicals and education and classes and learning and life and work and friend. So they're complex being, but while school is, yes, the important question is surrounding school, there are so many other areas that we need to pay attention to and ask our students for them to do it at an individual level. Say, how has it impacted you as a person? So here I share from a 21-year-old in an associate degree program, which would be the degree you get before you get a bachelor's. So in the US, we call it an LPN program. So I had to finish the last 2 months of my sophomore year of college online. I was restricted of having a job for 3 months. I'm restricted from seeing my family members at a risk of getting the virus. And here we see the fear. Yes, I'm disappointed about finishing it online, but the true fear was, how do I put my other family members at risk because I'm still in an environment where I might get exposed? Another one specific to education, and this is from a 21-year-old from India. It makes education less effective because there may not be any direct contact with teachers. And I want us to pay attention to this because, again, we saw 65% of them wanted in person, but the wanting in person is the direct contact with teachers, which I felt, this is not the classroom teaching that we're talking about. This is the opportunity to have that conversation right after class, or to come to someone's office to say, I have a question for you. So again, the content delivery is good, but making ourselves available even in a virtual setting is sometimes more powerful to students than just delivering the content. How do they cope? The student shared, 33 years old, from Maryland in the US. I moved in with fellow students to help maintain the feeling of being in a cohort. And again, this perfectly aligns with what our students shared to say, do I have access to resources? But that resource did not mean computers and internet. It's the friends and their cohorts and this feeling of belonging. Much of our work in the medical field and nursing can sometimes feel a very lonely journey, and sometimes the only way we get through difficult assignments is being with a buddy or having that sense that you're in a cohort of individuals that's experiencing the same thing. And this, I thought, was a powerful experience shared because they took the step to actually move in with their friends just to give themselves a chance of being successful. One of the things that usually happen when you get lost in your research and you think you're doing a fantastic job is, so what and who cares? And this is all great information, but what does it matter? Yes, it matters to nursing, but I just want to point out that it's a global issue. It's affecting everyone at the same time. And so we have to stand up and pay attention to what our students are saying across the globe. Our student profile is again very important. They're very young, mostly first degree, mostly women, and mostly unwed. So these are individuals who need all the support they can get to have a career in a very challenging area with everything currently working against them. Change versus resistance versus time, that we're going through change, but there's not very much resistance expressed. It's more, how do we cope? But more importantly, what will this look like in a few months' time? Again, what is not said, and this is another area that I usually try to think about, is we hear some statement, what was not said is, I'm going to quit nursing school. I don't want to do this anymore. That was not shared at all from none of the responses we get, which I thought, these individuals are in this career for a long haul, not just a job. Who is responsible for helping? So we know all these things. Who is responsible? Is it at an individual lecturer to student? Is it peer to peer? Or is it institution? Now that we have this data and we shared in a historical perspective that we've seen a version of this before, did we respond to those calls? And what do we do now? I would propose that at minimum at an institutional level, we have to respond to, how do we make a better connection with students who want that direct face-to-face. We can still achieve that virtually, but ensuring that we actually do it. And what are some of the lessons that we're going to learn from this that we haven't finished learning yet? But what are some of the lessons that we're learning from this that we can not just learn, but make as meaningful changes going forward? And I won't say for the next pandemic, because that will just be a terrible thing to say. But I will welcome your questions at the end of the presentation, but thank you again for your attentive ears, and I'll hand it back over to our moderator.
Thank you very much, Dr. Rodney. Everyone, Dr. Rodney start with emphasize this is a rapid change in students. Then we have to change from the on-site to the online. And Dr. Rodney threw the question that how we ensure that students will get the same outcome, because they have many factors that we have to dealing with, such as most of nursing is practical. How do we ensure that students have the same experience between on-site and online? And students may have some supporting system, including the resource that you will give to them, as well as the support from the employee and the staff. And Dr. Rodney implement this study in not only in the US, so I'm sure that they have some sample in Thailand to respond on this questionnaire. And the result is very surprising that 23 of students had at least moderate level of anxiety, and straight more than 50% report that 67% of them had straight more than 50%. And in the final of her presentation, she asked that, so what and who cares? I think this is very important that we have to concern. This is a global issue, as Dr. Rodney said, and we have to help each other to make a change in the meaningful way for our students. All right, let's move on to our second speaker. She is a professor at Faculty of Science, Medicine and Health, School of Nursing, University of Wollongong, Australia. She is also a director of Center for Evidence-Based Initiative in Healthcare, a GBI Center of Excellence. Our speaker is passionate about evidence synthesis in non-communicable diseases, the research on the clinical nursing workforce, and teaching and learning in clinical setting. Her topic for today's webinar is psychological impact among nurses during COVID-19. Please welcome Professor Dr. Ritin Fernandez.
I'll just share my screen. Can you see my screen?
Yes.
Okay. Thank you very much, Dr. Thitithep and the MU-JHU Research Collaborative for inviting me for this presentation. Tama, you've done a fantastic job with the students and a lot of hard work, both in the US and in Thailand. So congratulations on a job well done. I'm going to take another angle and I'm going to talk about the mental health impact of COVID-19 in the clinical setting among registered nurses. So it's interesting because the COVID-19 impacted not just the students and the clinical nurses, but it also impacted a lot of the academic staff, including the professors. So we professors got together and we thought, well, let's do something about it and identify what are some of the issues that clinical nurses are facing, what's happening, how are they feeling during this pandemic. So in March, we decided to form a research team. And this is our research team and our administrative assistant, Sophia Russo, who is the backbone of our whole team. I really like to thank her and our whole team for helping us out with this project and helping us successfully complete all the projects. I'd also like to take this opportunity to thank all our frontline staff for all the hard work that they're doing everywhere around the world. So we all know the story. On 30th of January 2020, WHO declared COVID-19 a public health emergency of international concern. And on the 11th of March 2020, WHO declares COVID-19 a pandemic. Before I talk about the research studies that we've done, I'd like to give you some context of how the pandemic played out in March of last year. So as you can see on this map, that the pandemic was widespread all throughout China, Asia, the Americas, Europe, everywhere. And thank God, it just missed. We had very, very few cases of COVID-19 last year, as you can see in Australia. Our cases were less than 100 cases, while the rest of the world had thousands of cases going through. So just to put in perspective, at the time we did this study in June, so we did the study somewhere in April, May, and June. So in June, we had only 7,521 cases in Australia. As of today now, we have got 39,615 cases and 965 deaths. So our country has got quite a lot of cases at the moment, but not as high as compared to other countries. In New South Wales, which is one of our states in Australia, we had very few cases at the time of our study in April of 2020. But as of this morning, we have got 14,227 cases, 210 deaths, and our state is in complete lockdown now at the moment. So in Sydney, which is the suburb, which is the city that we live in, we've got 6,177 cases and 210 deaths. And in southeastern Sydney, which is a region where we conducted the study, there are, as of today, 522 cases. So some of the cases are in hospital and some of the cases are at home. We've got very few cases in the ICU at the moment. So it looks like the COVID-19 pandemic, we've got the second wave, and the second wave, the variant, has hit us really, really badly. So this is the situation we have at the moment. But going back to March and April of last year, when we had very, very limited cases, we decided to do a study. Before I go into the study, what our government did in response to the pandemic was they closed the borders to all non-residents, and the borders are still shut, so we still can't leave the country and go out to Paris and France for holidays, which we would love to, or even to Thailand. And the social venues, educational institutions, restaurants were all closed. So we went straight onto online teaching. And like Tama said, we had a lot of issues with students, with the online teaching, with students, staff, and the infrastructure. So there were issues relating to that. Large gatherings were prohibited. People were asked to work from home where possible. So the whole of last year, a lot of our universities, the staff and the students worked from home and they were taught online. Social distancing rules were imposed. We still have the social distancing rules now. At the present moment, we can't travel more than 5 kilometers away from our house. Public health campaign, there was hand washing, social distancing, and getting tested. And initial warnings were given, followed by monetary fines for offenders. So this was the response that the government took in response to the pandemic. So our first study we looked at was, we thought we'll look at the well-being of ICU nurse, because you wake up in the morning and you turn on the television and you find the news about how ICUs are being overwhelmed, and football grounds in the US and in other countries have been converted into makeshift ICUs. So it was all about ICUs and how ICU nurses were struggling with the lack of PPE and the lack of ventilators. So this was the news that was coming through us every single day. So we decided to first look at the well-being of ICU nurses. And mind you, at this time, we did not have a single case of ICU single case of COVID in our hospital. So the ICU nurses were preparing to to accept patients with COVID-19. So in March, we collaborated with the director of nursing, and we asked them to join the team. We developed a survey comprising of validated questionnaires and some investigator-developed questionnaires. We got the ethics approval. We conducted the survey via SurveyMonkey. We completed data collection in mid-April, did the publications, and provided the report to the director of the hospital. So what were the results of our study? We have about 200 nurses working in our ICU, of whom 83 ICU nurses responded to our survey. We thought the response rate of 42% was pretty good, knowing that response rate among nurses is pretty low normally. And 66% of our nurses who responded were aged below 35 years, and the majority of them worked full-time. A quarter of the nurses had worked as a registered nurse for 3 years or less. And half of them had worked in the ICU for 3 years or less. So there were only 50% of the nurses who had experience working in ICU. So we assessed their anxiety using the 6-point STAI scale, State Trait Anxiety Inventory. And we asked them about their concerns and whether they were willing to work in ICU. And what we found was that they had high levels of anxiety, and 90% of the nurses were concerned about spreading the COVID-19 to their families. And that is true of every person working in ICU or in a hospital setting across the world. What was very interesting is about 61% of the nurses indicated that they were willing to care for their patients with COVID. And the reasons that they said that they were willing to care for the patients with COVID was because they received timely communication from their managers. And this was the only predictor of willingness to care among ICU nurses. So in short, effective communication from the leaders was really key to providing the nurses with the information that they needed. Because at this time, although we did not have any cases of COVID in the hospital, the situation was changing by the minute worldwide. And as the situation was changing by the minute worldwide, the ICU nurses felt that they were getting the information that they were getting was very timely and very succinct information so that they could care for their patients with COVID. So this demonstrates that ICU nurses have a lot of resilience throughout the pandemic. And although we did this study before the pandemic, when there was when we had no cases, nurses were really anxious about what's going to happen when the cases come in. Now we have got our ICUs are nearly half full with patients with COVID. We've got a couple of wards that have got COVID patients. I'm not really sure at the moment what the anxiety level would be, but maybe now they know and they've learned from experiences of other countries, and now they can see it firsthand. So I'm hoping that their anxiety levels are not as high as what it was when they had the fear of the unknown. So approximately 60% reported receiving sufficient information from managers regarding COVID-19 about caring for a patient with COVID. So we then decided to see what is the mental health impact of COVID-19 on nurses, on health professionals globally. So we decided to do an umbrella review of the literature. We thought we'll do a systematic review, but when we started to do a systematic review, we found that there are already systematic reviews being done across the world. So we decided to do a systematic review of systematic reviews, which is called an umbrella review. And we did a search date on March 21st, and we reviewed all the papers published in English. And these are the databases that we searched: the Cochrane database, the JBI evidence synthesis database, Medline, Web of Science, PsycInfo, Embase, and CINAHL. And we looked to find systematic reviews that reported on the prevalence and anxiety and depression among healthcare workers during the pandemic. And studies were selected by 2 reviewers, and we assessed the quality of the reviews before we included them. So we found that there were 100 studies that were published globally across 35 countries that looked at stress, depression, and anxiety among healthcare workers. Those healthcare workers could be medical, they could be doctors, nurses, health professionals, and other healthcare workers. So they looked at 169,157 health workers across 35 countries. Of the countries, the majority of the studies were undertaken in America and in China. There were a few studies undertaken in Europe and some in South America, but the majority were in China and in America. So what we found was the prevalence of anxiety and depression. So we then classified these studies into just those that looked at nurses and physicians. So we found that anxiety was present in about 27% of the nurses, which is quite similar to the students that Tamer had in your study, Tamer. And depression was present in about 28% of the nurses. Among physicians, we had about 19.8% of physicians had anxiety. But what's concerning is that 40.4% of physicians were depressed. And so this is the global study. And this 40.4% was out of the 5,820 physicians that were surveyed. And of the 14,938 nurses that were surveyed, 28% were depressed and 27% had anxiety. So this was a review of all the global evidence on anxiety and depression across the world. So we then thought that let's look at nurses who are the frontline workers working at the bedsides, not just the ICU nurses, but those who are working at the bedside, those who are working in outpatients and inpatient clinics. Let's have a look and see how they coped with the situation. Mind you, still at the time, we had no cases of COVID, and in this hospital. There were some cases across Sydney, but there were no cases in the hospital. So we developed a collaboration with 8 hospitals across our local health district. We developed a survey using validated tools. We received ethics approval. We commenced a data collection. We provided a report to the Director of Nursing. The publications were commenced, and we developed strategies to improve the well-being of the staff. So we collected data relating to age, gender, employment status, length of time they worked as a nurse, and their designation, the model of care that they provided during COVID, whether they had any information overload, any open-ended comments. We checked their anxiety, what were their coping strategies, and we asked them about their organizational commitment. So in this study, we had 568 nurses completed the survey, of whom 88.4% were female, which is very true for the profession. The mean age of the staff was 42.9 years of age, and they were employed as a nurse or a midwife for 6 months to about close to 50 years. And they were all different levels of nurses, right from a registered nurse to a clinical nurse specialist, clinical nurse consultants, managers, and enrolled nurses and assistants in nursing. What was very interesting from this study was that overall, the prevalence of anxiety was 56.5%. So we had more than half of our nurses who were really anxious within the 6 hospitals. The anxiety among nurses working in critical care areas, ICU and ED, was 60.7%. Anxiety working in non-critical areas was 55.8%. And those providing direct care, so those who were working at the bedside, was 56.6% of them had anxiety. And those who were not providing direct care, 54.4% of them had anxiety. There was no significant difference where, depending on age or the duration of the employment as a nurse or a midwife, and the level of anxiety that they had. But these high levels of anxiety has been really concerning. So we decided to implement some strategies in order to prevent, if we had the second wave, to prevent this level of anxiety. So we got these results analyzed. We talked to the Director of Nursing. We collaborated with our mental health practitioners and clinicians at the university, and we designed some strategies so that we could bring down, help reduce this level of anxiety. But then what happened? This happened we discussed all of this, and we were starting to implement the strategies when the second wave of the pandemic hit. And we have been in lockdown now since July. It's been July, August, nearly 8 weeks that we are in lockdown. And I'm not really sure what the level of anxiety is for nurses and how they must be coping at this point in time. But surely once we are able to, once the restrictions have been lifted, we'll try and implement some of the strategies that we have decided to implement. Some of the reasons potentially for this high anxiety levels could be, yes, the fear of getting COVID. Yes, they could take it to their family members. It could also be that there were some challenges to social distancing during COVID-19. So while these nurses were working in the wards, they found it very difficult to do social distancing. One of the comments that they had was, they provided us with comments, and we themed their comments. And the comments related to social distancing with patients. So they said, one of the themes that came in, sub-themes, was patient care. And a quote was, certain patients require, patients' procedures require close contact. Example, line insertions, log rolls, ETT, tapes, collar, just to name a few. So they were concerned, how can we do these procedures by social distancing? We can't maintain the 1.5 meter distance. The other sub-theme was the nature of nursing. We are taught the importance of touch is embedded in our practice of healing, making social distancing an anathema to our cultural practices. So this was what one of the nurses quoted about why they could not do social distancing within the ward setting. The other challenges to social distancing was social distancing with colleagues. So the physical space, they said our unit is a small cramped space. Staff rooms, nurses' stations, and wards are too small. So that was one of the barriers to social distancing in the wards. The people, my ward has all the surgical specialties, which means all the specialist teams end up on the ward at the same time with medical students. So that's another challenge that they had. And we need to do something so that not all the specialties come and visit their patients at the same time. So this is something we need to take to the next level and find out how we can overcome some of these barriers. The equipment, the area around the nurses' station gets crowded. It's where all the phones and computers are. So that was another challenge that nurses faced when they had social distancing. Adherence. So we are by habit social creatures that are naturally drawn into each other's personal space. And I think this is very true. And all of a sudden to do social distancing, not only for nurses, but I think for anybody, it would have been quite difficult. And it's quite difficult for nurses because of all these, because of how they are ingrained into touching and caring for patients. So these were some of the challenges that clinicians faced. And it could be possible that some of these things also contributed to their anxiety levels. The strategies to reduce anxiety. These strategies were implemented as soon as we started the lockdown in the country and social distancing had started. These were some of the strategies that were implemented. They were given special leave if they were affected by COVID-19 or they had to isolate. We had training in PPE, especially for COVID-19, so nurses could undertake the training for PPE. Some of the telecommunications companies gave free phone plans to nurses, to healthcare professionals. So all we had to do was give them our registration number and we got a month free of Vodafone or whichever company gave us the telecommunications. The local community support gave free meals, free coffee and food vouchers for health professionals. The government funded online course in critical care. So that was another method to reduce anxiety. Free staff parking, and there were relaxation rooms and staff gardens. So these were some of the strategies that we implemented to reduce anxiety. What we thought was now, after we found the high rates of anxiety among our nurses, we thought of having a team building exercise outside, somewhere out in the bush, so that nurses could go out, relax and regenerate and recuperate and come back, with a better outlook. But that's not happening at the moment because we can't go anywhere other than 5 kilometers outside our hospital. So that will have to be on hold for some time. Thank you. So those were some of the things that I would like to share with the team.
Thank you very much, Professor Fernandez. Everyone, Dr. Fernandez has emphasized about her study on the well-being of the ICU nurse, and she also expanded into the non-ICU. Yet we found the same thing, that they have a high prevalence of anxiety, which is very surprised. Is still concur with her umbrella review as well, that we have some amount of number of prevalence in anxiety and depression. And she in the end of her presentation, she talked about the challenges of social distancing for healthcare provider. For the patients, it's very hard for us to stay away from the patient because we have to take some procedure that we need to do the close contact, or maybe some culture like a touching. That's a very important culture in Australia. And to stay away from the colleague is still very hard because the hospital has very limited space, or maybe we have to work like a team, so we can to go like a team and we have to communicate to each other. And nurse is the center of healthcare provider that we have to contact with another healthcare providers. And she ended with a strategy because we found that anxiety is a very important factor. She ended up with a strategy to reduce anxiety, such as we have to do like PPE training, or we have to give some incentive like the free meal or free coffee and the phone plan or something like that. And lastly, I think this is very important, that we have to set up like a relaxation group or some space to help each other to calm down during this pandemic. Thank you very much, Professor Fernandez. And everyone, we come to our last speaker. She's a Dean at Faculty of Nursing, Mahidol University, and also the Director of the WHO Collaborating Center for Nursing and Midwifery Development, Thailand. Besides her duty as a leader of the organization, she is still active on research emphasizing mental health nursing and improve the outcome of care in patients with psychiatric disorder. Today, she will present on the topic of a cross-country comparative study of psychological impact during COVID-19 pandemic on the university students. Please welcome Associate Professor Dr. Yachai Sittimongkol.
Thank you very much, Dr. Thitithipong. Can I share my document? Yes. Did you hear me?
Yes, we can hear
you.
you.
Good evening. I feel like, very exciting when I listen to the presentations of Professor Fernandez and Assistant Professor Rodney. You have done a great job, and I feel that my study is quite very small when comparing with you. But anyway, thank you very much for inviting me to join this webinar. And I would like to share with you about the research work that my colleagues from Indonesia, Taiwan, and myself from Thailand have done a research work entitled Anxiety and Suicidal Thoughts During the COVID-19 Pandemic. This is the cross-country comparative study among these 3 countries. And the participants, yes, they are the university students. And this is my faculty. It's located on the riverbank, on the Chao Phraya riverbank. If the situation has been declined, so please come and visit us. The studies that I have done with my colleagues, that's already published in the journal. And I would like to say thank you very much for the principal investigator, Dr. Iqbal Pramukit, and other colleagues from Australia, from Taiwan, and from Thailand and Indonesia. They are great. As both of you has done great job with nursing students and registered nurses, and both of you agree that they are depressed, they are anxiety. So I think this is the similar situation. Why we have to focus on university students? Because as WHO declared the COVID-19 outbreak as pandemic in 2020, of course, in Thailand also. Its spreading has erupted on the last week of January 2020 in Thailand. And of course, there are a lot of stress and anxiety among university students. And the university students, because we can say that the COVID-19 pandemic become the major life stressor that has much influence on people's and students' lives and psychological well-being. They feel fear of being infected and anxious about the government reactions in transmission control, because at that time, it's just 2020, this is the starting, no one know what we could do. So they feel more depressed when receiving the threatening COVID-19 news. And of course, they have to have social distancing, feel lonely. And plus, the university students has a lot of stress in terms of many universities have suspended classroom and switched to online teaching. So they have a critical challenges also, because this gonna interfere with their plans and affect their future careers, as you know that, because they are expected to begin their career after graduation, and they have to learn knowledge and skills to use in their future career also. So this is challenging. Then we decide, I mean that, because we as a group, we call APAIN. This is the group that we consist of many countries: Thailand, Taiwan, Indonesia, Japan, Philippines, and Turkey. We form as Asia and Pacific Alliance for Nursing Education. When we discussed with each other, we thought that we agree to do a research, and the aims of this research is to compare the psychological response toward COVID-19 and its related factors among university students in 3 different countries: Indonesia, Thailand, and Taiwan. We employ the theoretical frameworks. First, the health belief models, and the second one is protection motivation theory. Based on health belief model, it posits that perceived susceptibility, perceived severity, and perceived benefits are the major contributors, enabling individuals to take specific health behavioral actions. Based on protection motivation theory, it also posits that individuals' health-related behaviors are triggered by the psychological distress. Therefore, the factors that we are going to examine for our study based on the health belief model is that perceived susceptibility and perceived severity. Based on perceived susceptibility and perceived severity, we use risk perception of susceptibility to COVID-19. And for perceived benefits, we measure about confidence in pandemic control, and perceived support and perceived sufficiency of resources under perceived benefit. What we measure as the dependent variables, we measure anxiety and suicidal thoughts among university students. We employ a multi-country web-based cross-sectional studies, and the students from 4 public universities, including 2 universities in Indonesia, 1 university in Taiwan, and 1 in Thailand. The total number of the university students is about 1,985, and the majority of university students come from Indonesia. And the participants were recruited through social media platforms such as Facebook, Line, WhatsApp. We conduct this study. We collect data from April 10 to June 30th in 2020. What the measurements that we use for our study? First, the confidence in pandemic control. We assessed the personal, city, and the university, how they feel confidence in these three categories in handling the pandemic situation. In terms of risk perception of susceptibility to COVID-19, we measure absolute susceptibility and relative susceptibility. Among perceived support, we assess them that did they perceive support from families, classmates, and faculty. In terms of perceived sufficiency of resource, we measure about how they perceive or what they perceive sufficiencies of PPE, COVID-19 information, money, medical resources, and psychological support. For the source of COVID-19 information, we ask them about the seeking information from various sources. This includes the internet, medical staff, and their own family. We use state trait anxiety inventory as the measurement for measuring anxiety. But in terms of suicidal thoughts, we use suicidal thoughts in the past week, just only one item. ANOVA and chi-square test, Pearson correlations, and multi-group structural equation modeling were used to analyze data. The results show that approximately 80% of all participants were female, with 82% of the participants majoring in medical-related programs and about 81% studying in the undergraduate level. Particularly, Taiwanese sample comprised more males, and the Indonesian comprised more medical students. In Thai, the Thai sample comprised more postgraduates. The results revealed that among the three groups, Thai students had the highest levels of anxiety and the lowest levels of confidence in pandemic control and available resources for fighting COVID-19. In Indonesian country, students, they had the highest levels of risk perception of susceptibility to COVID-19 and perceived satisfactory support from different sources. Among Thai students, they received more information from the internet, while Indonesia received more information from medical staff and family. What are factors associated with psychological response? We found that the confidence in pandemic control, risk perception, sufficiency of resources, receiving information from internet, medical staffs, and families, all are factors associated with the high level of anxiety. Among other factors, we found that confidence in pandemic control, perceived satisfactory support, sufficiency of resource, receiving information from the internet and family are all factors associated with suicidal thoughts. When considering the results of the university students in each country, in Indonesia, Indonesian students, we found that greater perceived satisfactory and greater perceived satisfactory support and receiving more information from medical staff significantly explain higher level of anxiety. This is very interesting. And then we found that less perceived satisfactory support significantly explain more suicidal thoughts. In Taiwanese students receiving more information gathered from the internet and medical staff significantly explain higher levels of anxiety. Look at Thai university students receiving more information from family significantly explain higher levels of anxiety and less perceived satisfactory support, and receiving less information from medical staffs significantly explain more suicidal thoughts. We can conclude that the university students from different countries had different levels of psychological responses related to the COVID-19 pandemic. As you can see that Thai students had the highest levels of anxiety and the lowest confidence. For receiving more COVID-19 information increased the anxiety levels, but not in relation to suicidal thoughts, and received less satisfactory support was associated with more suicidal thoughts among Indonesian and Thai students. Based on the findings of this study, there is a need to healthcare providers. They have to provide the university students with reliable information to increase their confidence in COVID-19 pandemic control and provide sufficient resources in dealing with the psychological impact. Healthcare providers need to provide, or the administrators need to provide sufficient PPE, accurate information, monetary and medical resources, and psychological support to the university students. And they need to encourage students to obtain COVID-19 information from trusted sources such as medical staff rather than from the internet and social media. However, there are some limitations of this study. There are three things that we need to inform. First, the majority of the students were female, like almost 80%, and majoring in medical related programs. Thus, the generalizability of the findings may be restricted. The sample representative is also restricted due to the sample size being different in the three countries studied. Taiwanese sample was relatively smaller. The country comparisons are limited, and all measures were assessed using self-reported. The bias of social desirability and common method variance may influence these results. Thank you very much. ขอบคุณค่ะ
Thank you very much, Dean Sittimongkol, for your presentation. Everyone, Dean Yachai emphasized us about her study on the comparison of the impact of COVID-19 among three countries, Thailand, Taiwan, and Indonesia. We found the same thing in common, that anxiety is the same problem that happen in university students, and the factors that influence on these three countries that's found in the same trend is confidence in the pandemic control, risk perception, and sufficiency of the resource that may contribute to the importance of the support for the student during the COVID-19. However, Dean Yachai report that we found some significant factor that are important and significant difference among these three countries, such as Indonesia report that the satisfaction with support is the important factor among them. And for the Taiwanese, is about the information that received from the internet is the important factors, while Thailand is the support from family is still this important factor. This is make that three countries that have a different factor that contribute to the COVID-19 impact on the psychological health. So thank you very much again, Dean Sittimongkol. And everyone, I will have Dr. Tamar, Dr. Fernandez, and Dean Yachai back for the Q&A session. If you have any questions, please type in the chat box so we can read them to our speakers.
Good evening. May I have a question, please?
Of course, sure. Please.
Yes, please. I'm Jirapon Tampakpi from Faculty of Nursing, Khon University. Sawadee ka, Ajahn. Yes, I wonder that do you have an incidence of the student dropout? Meanwhile, they're facing the COVID pandemics because of uncertainty on the safety of their health or advice about the changes of the teaching and learning. Thank you.
Sorry, Dr. Jirapon, right? What the question is belong to which presenters?
Anyone, right?
Yes, อาจารย์ยาใจค่ะ Thank you ค่ะ
Okay.
ขอบคุณค่ะ
Thank you, Dr. Jirapon. Thank you very much for attending this second webinar. I think that, you know, from now on, from my experience and the situation of the Faculty of Nursing Mahidol University, there is no one drop or, you know, withdraw from studying in nursing profession in our faculty. But anyway, it surprised me that when we like, you know, for this year in the academic year of 2021, there are lots of students in high school. They are very interested in study in nursing in many universities, including Faculty of Nursing Mahidol University. That's surprising me because I think that they probably feel so fear and anxious and don't want to be healthcare professionals like nurses. But there are lots of candidates who are interested in studying in nursing.
Thank you so much ค่ะอาจารย์
Okay, I have one question here, maybe for Dr. Tamarati. There is uncertainty regarding the end of COVID-19 pandemic and maybe the new strain of virus emerging. Online learning has become the solution to complete the course or curriculum. However, it may not address the clinical practicum components. I would like to ask Dr. Tamar that how we solve all this problem.
Well, this is a huge problem you're asking me to solve, but I'll take a stab at some of the things that we've been able to do. So that's a great question because we're able to deliver the didactic component, but how do we solve the issue of clinicals? And we have been able to do some virtual clinicals. At Johns Hopkins, we have a robotic arm, and so we can simulate some of the experiences. But adhering to social distancing guidelines, we have been able to take in some of our students in limited numbers. So we're just not doing it as efficiently as we would normally do. So maybe instead of 20, we'll have 6, but still trying to achieve the same goals. And on the clinical setting, you know, they're still patients, they're still preceptors. And so we have to adhere to the same guidelines to say not as many students in the clinical environment, but as many as we can, substituting with some virtually and getting as much hands-on experience as we possibly can. I would also say that what this has done is force us to be more creative. Not necessarily inventing anything new, but knowing how to use the resources that we have more efficiently, smarter, and realizing that nothing is changing with individuals needing care. It's just how we provide that care. And this extends to that care that we provide in a clinical setting. So I say that in a wonderful sentence as it's easy. It's not, it's really not. But if we adhere to everything as in protecting ourselves, similar to how we would have dealt with any other infectious disease, I still think we can create opportunities to provide meaningful clinical care to our students, even if it's in a more limited reserve setting. And somehow we're still able to do that. You know, we're nurses, we get very creative when we need to.
Thank you, Tamar. And I have one question is come to directly to me, not in the public. Is for Professor Fernandez. It's about you mentioned about your results. You will inform like the director of the hospital or maybe the policy maker of the hospital, because that your study may inform something to the policy maker level. And the question is how you get negotiate or convince the head of the hospital to launch some policy to improve, like some policy to help the nursing at the frontline service. You have to unmute. Thank you.
Thank you for that question. It's a very difficult task to try and convince the policymakers. But what we did was right from the start, from when we started the survey, we involved the people who would actually are responsible for making the change, like the director of nursing. Involve them in the study and keep them informed of the results as we are going throughout. So as soon as before we publish the results, we actually sent it to the director of nursing, and we said to them, these are the results. These are really high results. What would you like to do with them? Because we're going to be publishing the results, and we need to do something so that we can say that we've got these high levels of anxiety. We need to do something for them. So I think I was fortunate because our leadership was very good, and we involved them right from the beginning. We provided them with time-to-time feedback on what was happening, and they saw the potential, and they saw that there was a gap. We need to reduce the anxiety, and therefore they started. We are now planning strategies on reducing the anxiety. So the bottom line is involve these policymakers right at the start of your study.
Okay, thank you very much, Dr. Fernandez. And this one, I think this for Tamar, about the number of students that during COVID-19 situation, the number is increased or decreased because they may have some limit number of nursing students on board practicing.
Here is the funny thing about that. Admissions have increased, and I think there's even more increased vigor, want to enter the profession of nursing. We've certainly shed a spotlight on nursing. We continue to be most trusted, and the backbone of the healthcare industry, as I dare say. So the importance of our role in not just providing care, but literally keeping individuals alive is not lost on individuals looking on. And how we respond to the challenge has been absolutely stellar, outstanding. And those are some of the things that are the best adverts for students wanting to enter the profession of nursing. And so if the only silver lining is that we might increase our nursing workforce, here is that opportunity to do so. So on the contrary, I honestly thought that we were going to see less students, but particularly in the programs that I teach in, I've seen one program a 34% increase, and the other program small percentage increase, but still an increase, so still wanting to be engaged in a career, even when things are probably at its lowest.
Yeah, and one question for you, Tamar. Do nursing students need to receive tests such as saliva or ATK tests for COVID during studying on lab or clinic?
So luckily, we're in an era where we do have vaccines available. So thankfully, the majority of our students chose to get vaccinated, and it's actually now become a requirement to engage in clinical practice by the school and by the clinical environment. So I would say all of our students who are engaged in clinicals, clinical practice, clinical rotations are vaccinated, and then alternatively tests are easily available if needed. And because we're in a global audience, I do recognize that this is not an opportunity afforded to everyone, but in our current environment, that is afforded, and our students are also responsible and responsive to that challenge to continue clinical practice and to keep everybody else safe as well. It's not just mandating something. The reason that we're mandating this is to keep not just themselves safe, but their patients safe and their families that they go home to. So yes.
Yeah, thank you. And I think we have one last question for Dean Yajai. As you conduct your research at 3 countries, the question is about the result of your research will be generalized to worldwide or not?
Very good questions. Like I told you, the first thing that the limitations of the study is because this study, we recruit many students who are female and medical related program. And I would like to say that if you would like to generalize the findings of this study to your countries, I think that dealing with COVID-19 is still related to the culture of the countries and also related to the government, the government's reactions to transmission control also. So it's gonna be different. So I would like to encourage you to do the research work like this in your own country because of the different culture, the different government reaction to control the COVID-19 pandemics and other things, because the lives of students in the university also different also.
And Jinjachai, very last again. What about the Thai student admission plan for Faculty of Nursing Mahidol University? Can it decrease or increase?
Wow. We still have to enroll nursing students as planned, because every 4 years we have to propose the number of enrolled students to the government and the Thailand Nursing Council. So we need to do as we promised to the council and the government. So we cannot do more or do less.
Okay, thank you very much. All right, everyone, on behalf of the MU-JHU NCD Research Collaborative Center, I would like to thank you, Assistant Professor Tamar Rodney, Professor Ritin Fernandez, and Associate Professor Yachai Sitimongkol for being our guest speaker for today's session. Thank you very much. And everyone, before I close this webinar meeting, I would like to inform all guests about our next webinar meeting. So please see the brochure. The next webinar meeting is the third webinar meeting of our MU-JHU NCD Research Collaborative Center. Will be held on October 2021. So stay tuned for the date. We will publish soon, but will happen in October for sure. The topic is non-communicable diseases and lifestyle factors on biomarkers. We have 3 speakers. First, Dr. Runapha Ruishop from Faculty of Nursing, Mahidol University. Second, Bumi Okubi from School of Nursing, the Johns Hopkins University. And the last speaker is Dr. Catherine Maki, NIH and University of Illinois at Chicago College of Nursing. So please register for our next webinar meeting. And the last thing, we would like to hear from some feedback. So please complete and submit the evaluation form for us to improve the next activity of our center. Thank you very much, everyone, for joining us today. Have a great day and a great night. See you again next time. ขอบคุณครับ
Thank you, everybody.